जाग्रता भोजन्तु विश्वताः।
Section. Her LMP is on 12/7/2016, EDD is 19/4/17. Booked case on examination, only mild pallor present, her vitals are stable. Systemic examination, no abnormality detected. And perabdominal examination, single live intrauterine fetus of term gestation, longitudinal live, cephalic presentation, mobile head, clinically liquor adequate, no scar tenderness. Vaginal examination, okay. Unfavorable cervix and pelvis is gynecoid. Bishop score was 2, sir, for this patient.
The indication of last section?
Fetal distress.
With the indication of a section, can you make out the integrity of the scar with the history starting from the indication? What are the points you are going to take? Please come on.
It's a clean-cut Caesarean section. We are telling you only indications. Fetal distress. We took when the cervix was 5 centimeter dilated, membrane just ruptured, meconium stained liquor, fetal heart 80, irregular, shifted for section. Integrity of this scar.
Integrity of the scar in previous rupture, premature rupture of membranes means scar integrity.
See, 5 centimeter membrane just ruptured. They ruptured in active labor.
Is not premature rupture of membranes.
Institute where it was done is also.
Scar to be good or bad?
Will be good, sir.
Good. Is the patient can be given the trial of labor after C-section?
That patient.
This patient, fetal distress?
this patient.
Not this, I mean, this indication patient.
Can be given, sir.
She can be a candidate for trial of labor after C-section. TOLAC, not VBAC. VBAC is successful delivery, TOLAC is trial, right? Second case, PROM, cervix undilated, leaking started, more than 48 hours at home. She came to labor room, dry labor, not a single drop of liquor in uterus, shifted for section. Now her scar.
Scar integrity is poor, sir.
Scar integrity poor. Reason.
Chorioamnitis.
48 hours are over, right? So setting up of infection in the uterus. Third, patient came with pulse 120 per minute, abdomen distended. You can very well make out the gaseous distension above the uterus. Cervix is fully dilated, more than 6-8 hours. Patient was in labor for 3 days. Bladder distended up, drawn up. Vagina dry, hot, foul smelling. And the diagnosis is obstructed labor here.
Poor integrity.
Poor integrity of the scar. We
Poor
cannot go
integrity
for
of
trial
the scar. No? Okay. Fourth one, elective section. For ARS negative gravida, her ICT was positive. Intrauterine, intraperitoneal transfusion was given at 34 weeks. Section was done after the lung maturity check and steroids given. Now scar.
Good integrity of this scar.
Good or bad?
Good.
Good, bad, ugly. I think we can put the third one.
Good, sir.
Here the third also can come. Come on. Think.
34 weeks.
Done at 34 weeks, sir.
Chalo. Huh.
Difficult opposition of the edges.
Fourth
Lower
patient.
uterine segment is still not found.
Fourth patient. Unfortunately, spontaneous placenta previa. There is no scar on the lower uterine segment. She had probably second or third gravida, placenta previa. Caesarean section was done in the past, now. The anterior placenta that was reaching the interlos, not covering it. Incision taken, placenta incised, baby delivered, placenta delivered, now the scar.
Poor integrity, sir.
Why?
Placenta previa.
What can it happen? What can it do?
It can
Over enthusiastic junior resident doing Caesarean section. Included lot of decidua in the suturing and each and every stitch was interlocking. by 1 number of polyglycolic acid suture. This end to that end. My first Caesarean section, I am happy. In the evening there is a treat.
Deciduous should not be included.
वो मुझे नहीं मालूम, उन्हें किया. मैंने नहीं किया जी. अभी स्कार बोली है. Interlocking with inclusion of the decidua. Good, bad, ugly scar. So many shades of C-section scar.
One more last scenario.
Gray shades.
Post-operatively, she does has sepsis. She has sepsis, very bad, chorioamnionitis, whatever.
Post-operative foul smelling vaginal discharge with fever, with leukocytosis, with raised C-reactive proteins,
Poor scar integrity.
poor scar healing. Post-operative, she has developed extensive urinary tract infection, scalding micturition, but no foul smelling uterine discharge.
Only micturition. Bolo.
है ना?
So difficult it is.
हाँ, क्या डिफिकल्ट है जी? वो कैथेटर डाले ना, एनल स्फिंक्टर में डाले वाला कैथेटर यूट्रस में डाले, ब्लैडर में डाले, हाँ, हो गया यूटीआई.
Scar integrity, it will be
Good, bad, ugly. Infection somewhere else, not in the uterus.
Bad. So good integrity.
Okay, patient is having chronic suppurative otitis media. Draining from a ear, you are not able to tolerate that smell. You did the C-section. Infection in the ear, scar over the uterus. Will it heal properly or not?
No proper healing.
No
क्या
proper
मालूम?
healing.
हाँ,
No proper healing.
healings.
मुझे नहीं मालूम, आपने बताना है. Okay, now, how to judge the scar integrity? When the patient is in labor, you allowed her for a trial of vaginal delivery. How to see for scar tenderness?
In between the
During the
contraction,
process
In
of
between the
the,
contractions, we will check for scar tenderness.
during relaxation or during contraction?
in between
the contractions.
That means during relaxation period.
we will.
To stand on right side of the patient or left side?
right side.
Whether patient's bladder should be empty or fully distended.
Bladder should be
Bladder
empty.
should be empty.
And she is waiting when she is going to pass the urine or somebody catheterize. To check the scar.
Which part of the hand is
Bladder
Ulnar
should be
border
full
of the
or
hand should be used.
Palm.
Ulnar
hand.
border.
Which part of the hand should be used? Finger
Ulnar.
this
Either fingertips or ulnar border.
or this one? Fist. Fist of fury.
Either ulnar border or palm.
How to
inside the
palpate? From
finger.
right end to left end or left end to right end? Dextro-rotated uterus.
Centralize the uterus.
The Caesarean transverse scar. Moved more on right side.
Correct.
Correct the
Fix
dextro
the
rotation.
And then palpate.
left.
If you don't correct it, then you are not able to palpate the entire length of the scar. Scar rupture, scar dehiscence, same terminology or different?
Different.
What is the difference?
All the layers of the scar are gone in scar rupture, except visceral. If some part of the scar, like visceral peritoneum and fetal membrane.
See, we always say the fetal heart rate, they show abnormality when the scar gives way as an early first sign. Why? Baby is supplied by uterine arteries. Then why this scar giving way should cause fetal problem, cardiac problem?
Nearest to the scar. Fetus will be
Got.
nearest to
They
the
got
scar.
intelligent boys. क्यों होगा? बोलो. सोच के बोलो. Think and tell, because we are here for tomorrow also. I want this answer.
ask the question, sir.
See, fetus is supplied by uterine artery that goes to the placenta. From placenta, blood comes. Placenta is in fundus, either on anterior wall or posterior wall, supplying nicely to the baby. Then why scar giving way down? That causes fetal heart changes. Even if you answer me tomorrow, you'll get Cadbury. Right? Okay, VBAC or elective repeat section. Either of this you have to select. Previous Caesarean section with BP 160 by 110. Term patient, 38 weeks. What to do? ERCS or VBAC?
VBAC.
Elective section or VBAC or collapse?
Elective section.
Reason.
Associate, her BP is 160 by 110, sir. Associated with
Previous section with hemoglobin 5.2 grams.
previous section
With hemoglobin 5.2 grams. 37.5
Poor
weeks.
scar
Now 2
integrity,
days less
so
here.
now we will go for
Elective
elective section.
Sure?
Yes, sir.
Previous section with serum bilirubin of the patient 3.8 milligrams %.
Yes, we
Don't know what is the diagnosis.
Even me too.
Only bilirubin is
Only bilirubin has raised.
So there are so many differentials for you.
VBAC or section, repeat section or VBAC. I think that's correct way.
The rapid fire round. Just stick to it.
HIV positive lady with previous LSCS.
Yeah, what is your call on this?
छोड़ दो फिर पास करते हैं हम आगे पूछ लेते सामने किसी को हाँ HIV positive first pregnancy HIV negative this pregnancy unfortunately HIV1 HIV2 both positive with previous LSCS 37 weeks completed vaginal or section
elective section.
She is on ART.
she is on ART
Viral load is well controlled. CD4 is excellent.
CD4 count is quite high pelvis is roomy
Then we
not adequate
VBAC.
Unless there is an indication I'm telling you in HIV.
previous LSCS with HBsAg positive patient
ये मुश्किल है.
नहीं ये तो सीधे ही नहीं करना है नीचे से सवाल ही नहीं निकलता है ना ओके नाउ रीजन
Hepatitis B.
Hepatitis. More transmission will
Maternal
be,
to
but fetal transmission.
प्रीवियस LSCS विद पेरिनियल वार्ड्स कितना आसान है अभी तो कुछ बोलने का जरूरत ही नहीं है
Elective section.
हाँ elective repeat section there is no question here no previous LSCS with hypothyroidism TSH 18 125 per day eltroxin dose still TSH is high repeat section or VBAC
VBAC.
sure
Reason बोलो.
previous section with hyperthyroidism now high levels of T4
Crisis is
unfortunately some general practitioner without knowing has started the patient on carbamazole
See, both are poor and
after controlling.
yeah
better to go for VBAC.
VBAC
Poor
है ना
anesthesia.
sure
One is arrhythmia, the other is thyroid crisis.
previous LSCS with GDM controlled
Well controlled.
expected birth weight of the baby 2.9 kg
ये सोच क्या बोला important.
controlled GDM patient is on insulin but weight is controlled HbA1c is 6.8 less than 7
And the weight of the baby is
3 kg okay 3 kg थोड़ा GDM के लिए थोड़ा 100 ग्राम बढ़ा दो
And baby weight.
VBAC or LSCS
justify your answer.
हाँ
You can tell both, you can justify both.
obviously
Just like United Nations Security Council, you, like that. You represent the country, you can. Come on, this
Baby
is what
weight,
is intellectual.
baby weight is average 3 kg
and
CPD is ruled out, sir. Roomy
3
pelvic.
kg where is the question of CPD now
We can go for VBAC, sir.
What problems still you expect in VBAC? I won't be sleeping. My consultant will be there. What problem you expect? एक बोलो, एक answer बोलो.
Previous scar integrity healing of
Where you expect the problem? Grouping shoulders here.
Shoulder
shoulder
distance.
distortion, but baby is deep.
VBAC, most important thing now, VBAC to be done with spontaneous onset and VBAC in the patient induced labor.
Yes.
Which one will have better prognosis?
With spontaneous onset.
It has to be spontaneous onset because effacement is mandatory before you do anything
of labor
here.
will be
है ना?
good.
Can we come to know that the scar is bad at hand before the labor? Can we come to know the scar bad at hand
Keloid
before
and
the labor?
hypertrophied scar healing by secondary indentation.
No. What is the methodology?
Methodology by which we assess the scar.
Thickness of the scar.
Ultrasound है ना?
Thickness of the
Ultrasound
scar.
integrity we can know. Thickness of the scar we can know. Any wedge defects also.
But still,
3.5 to 4
it has given erroneous results. Sometimes
Yeah.
way around. Okay.
Before pregnancy also some will do.
Anatomical thickness of the scar and physiological behavior of scar tissue, they are two different things. Even 1 centimeter thick scar, 1 millimeter thick scar even can sustain the labor, and 5 millimeter thick scar may not sustain the labor. So you are not
Does
here.
intraoperative technique of doing a section influence the scar in the future? I had a case once in the theater. 2 cases I wanted to do VBAC. Previous 2 sections I applied forceps, delivered. Okay, 1 section, there was a rupture. How do you explain that? Does the operating technique of the surgeon play a role in the scar?
Yes.
Definitely.
How?
Perfect opposition of the tissues.
Taking the excluding the decidua.
including whole thickness of the tissue.
Not
Hemostasis
involving
important.
the better separation
Des-
of the bladder, pushing the lower
Hemostasis.
hemostasis.
Securing hemostasis,
Anything
hematomas.
else आप बोलो एक आध point.
Then, bas.
No,
Okay.
that's okay.
Okay, good.
Very good.
Chalo.
So,